Welcome to this short webcast jointly presented by Better Value Healthcare and Optimity Advisors. Today, Neil Gray from Better Value Healthcare will talk about the opportunities that sustainability and transformation footprints have to realize better value healthcare for populations, and Neve Lennox-Jugani from Optimity Advisors will talk about how this can be implemented for success.
Oh, we've had fantastic years of progress in the NHS, 50 years in every healthcare system in the world. But at the end of 50 years of progress, we can see three mighty problems within every healthcare system in the world. The first of these is unwanted variation. And that unwanted variation, first studied by Jack Bamberg, reveals other problems. And these other problems may be grouped into two types. One is overuse. And overuse always wastes resources and sometimes harms patients, as you can see in the list. The second is underuse, underuse of effective technology, and that is sometimes accompanied by inequity. Now, these two linked problems, waste and harm, underuse and inequity, have to be tackled. They've also got to be tackled in an era in which need and demand will increase, but there'll either be no more resources or resources might even decrease. So that's the challenge that we face. And that can only be tackled by shifting the focus from our obsession with institutions to an obsession with populations. Next, please. So let's think where we've come from and where we're going. Now, for 50 years, we've seen amazing technological development. It's my time in healthcare from being a medical student, hip replacement, transplantation, randomized controlled trials. These have been the achievements. In the last 20 years, we've done evidence-based medicine, we've done quality improvement, and we've done some cost reduction. So these four things are absolutely essential. They're necessary, but not sufficient. You see, people get puzzled about the relationship between quality and value. But value is bigger than quality. So low quality care is low value, but high quality care may also be of low value. Knee arthroscopy, for example. Similarly, cost effectiveness. Interventions that are not cost effective are low value, but we're now seeing the use of interventions that are cost effective, but they're being used in patients for whom it's the wrong patient getting the intervention. So for the future, quality, safety, evidence-based medicine, prevention, cost reduction, they're all necessary but not sufficient. We need a new agenda. Next, please. This new agenda focuses on value. Now, value is a very tricky word. English is a very tricky language. I speak as a Gastarbeiter in England from Scotland for 40 years. In the plural, values means a bit principles. For example, this hospital's values are transparency and equality. In the singular, it's got more of an economic meaning. And we think of triple value. Personal value, that's value for the individual. Technical value, that's value for the population from the resources that have been allocated, and allocative value. Personal value, technical value, and allocative value. Next, please. Now, let's start with personal value. And this is an illustration of the way in which decisions are made by individuals. And it's the model we've used since we founded the Evidence-Based Medicine Centre in Oxford 21 years ago. So evidence is derived from the study of groups of patients, and it has to be related to the clinical condition of this patient. And that's what we call personalization. And you can see here in this diagram, even if we include genomic medicine, genomic information, it's still the same principle. That's sometimes called precision medicine. So personalized medicine is a broader concept than precision medicine. Precision is if you're using genomic information. However, what we've also got to do, and we emphasize this in the first editorial in evidence-based medicine in the BMJ in 1996 is to take into account the patient's preferences and values. So that's personal value. Next, please. Now, this is the most important picture in healthcare, drawn by Avedis Donabedian in 1980. So what you can see is, as you put more money into healthcare, the benefits go up and then they plateau. Unfortunately, in healthcare, the harm goes up in a straight line. The more healthcare we do, the more harm we do. This is again not to do with the quality. The quality changes the relative position of these lines, but it doesn't actually change the fact that these lines exist. And as you can see, if you take away the harm from the benefit, you get a J-shaped curve. A J-shaped curve. Next, please. Now, the allocative efficiency, is illustrated here. So there's a number of different levels of allocation. How much money goes into healthcare? That's political. How much money is distributed to different populations? That's political. How much goes into education, research? That's made by NHS England. Then, when we give the money down to a population, decisions are made about how much goes to people with cancer, people with mental health problems, people to children, to old people. And this is what commissioning should be tackling. But many of the commissioners have not actually tackled this properly. They've dived straight into continuing to focus on primary and secondary care. As we move to value-based healthcare, primary and secondary care are still relevant, but if you think of supermarkets, if you were running a supermarket, you'd be wondering about how are my Sainsbury's local doing compared to my Sainsbury's supermarkets compared to online. But really you'd be wondering, what's going best? Is it meat, fish, children's clothing? It's service line accounting, service line accounting. And of course, once you get into a program budget like respiratory, and I'll remind you, respiratory is £100 million per million population. So the STP for Northwest London, for example, it's probably about £200 million a year. But we've no idea whether that's being better used than in Northeast London. Then there's a number of big service lines within that. Bronchitis, COPD, asthma, and sleep apnea. So that's the next level of allocative value. And that has to be the responsibility of clinicians working under the guidance of the Sustainability and Transformation Plan. Next, please. So that's the background. We're moving from the quality era to the value era. Three types of value: personal, allocative, and technical. I just finished by saying that the personal and the allocative are two sides of the one coin. As you do more healthcare, now you can think back to that Avedis Donabedian diagram. So as you do more healthcare, it has population implications. Now when I do this in hospitals or health centers or town halls with the public in, I ask people, where have we gone beyond the point of optimality? And the same things come up. People with multiple morbidity dying in hospital when they'd rather have died at home. People getting chemotherapy in the last week of life. Not saying that no one should have it, but did they really know what the offer was? The last 10% of imaging increase. The last 10% of lab testing increase. Because these things are growing all the time. And elective surgery comes up. Now, as you put more money into healthcare, you start offering treatment to people who are less severely affected. And for those people, the benefit that they will receive is less, but the probability of harm is the same. Whether you're mildly affected by cataract or severely affected, the probability of the cataract operation goes wrong is the same. So as you treat more people, we're actually treating different people, and the individual citizen has to know what the balance of benefit to harm is going to be for them and their particular condition. So population healthcare and personalized healthcare are two sides of the same coin, and STP planning has to take that into account. So that's enough from me on the background to value, something I've been working on for many years, and we now pass over to hear from Niamh.
Thank you, Muir. And thank you for that really helpful grounding. I think one of the challenges that is facing transformation and sustainability footprints, and I put it intentionally in that order, is around value. It's a discussion that many of the footprints are having as part of the planning process, and understanding what that means for a different way of thinking and acting across a system to realize that ambition of population-based, person-centered and better value healthcare. The reason I've inverted the sustainability and transformation title is because of our belief, based on the evidence that we're seeing from other countries who are slightly ahead of us on this journey, that transformation is actually the crux of this. Sustainability can only be derived if the system transforms, and if it transforms in the kind of ways that Muir has just outlined in terms of realizing value. So the title of the 5-year forward view, of which the sustainability and transformation plans are a continuation, recognizes that this is a developmental journey. Some SDP footprints are relatively far down the road, others are really starting out. A key section in every SDP will be the implementation plan. This should include measurable goals, key actions and interventions, resourcing and investment requirements, and a timeline. This is a big ask across a whole system. We've used a readiness assessment tool as a good way of testing whether the implementation plan that STP footprints are submitting will deliver what we know from the international evidence to be the key features of successful integrated health and care systems that deliver for value and orient to the population. It's designed to be used at different points in the developmental journey as a dynamic tool. It helps systems identify priorities for action, interdependencies, and a critical path, focusing energy at the right areas at the right time from the right stakeholders. And to take you back to what Muir has just outlined, key areas at the initial stages are around purpose and understanding. Do all of the stakeholders in an STP footprint really share a common purpose and understanding of those, the triple aim, as it's now being discussed here in the UK, the triple aim of better patient experience, better clinical outcomes and better population health outcomes, and better value for money? Do they have solid partnerships on which they are building that shared purpose and understanding? Do they have a clear scope around the populations that are their priority focus, using the principles of value that Muir has just outlined? And are they engaging with that population and with the patients that they are serving in the process of design and delivery? We know that in the past, when we spent large amounts of time and resource developing these strategy documents at local and at national level, there's been a significant gap between what went into the document and the benefits realized in practice. STPs are designed to be different. The process of engagement with the whole system is meant to be inclusive, and all partners need to sign up to what goes into that plan. This should mean that what is actually delivered in practice bears close resemblance to what is on paper. The matrix that you see in front of us is a helpful one in terms of thinking through and testing what your plan is actually going to deliver. Our starting point and the lens through which we suggest all STPs should be viewed is people. Patients, Communities, the NHS, local authorities, voluntary sector staff and local decision makers will all make STPs successful. Money, technology and redesign processes will help, at least not hinder, but only people can make the change happen. To use Muir's words, it's an important enabler, but it is not the only, but process, finance and technology are not the most important. People will make change happen. So the soft stuff, as we all know, is the hardest to get right. The time and effort put into getting people involved and harnessing collective intelligence or creating a social movement for change at the beginning of the STP process will pay off in terms of accelerated, sustainable change in the longer term. Try and avoid short-termism. I know it's difficult in the current circumstance, but you need to hold your nerve. Be clear about the purpose and make a compelling case for change that is based on the principles of better value that Muir has just discussed. Build on existing plans. Don't reinvent the wheel and create a whole new industry. Chances are that locally you have some great examples of good practice delivering better value healthcare to your population or segments of that population. Use frontline staff and service users to deliver the change where you can. It is always tempting to set up a discrete program management office and manage it at a huge transformation like this as another organization or system silo, but this won't help you embed the system change that is needed. We talk about harnessing collective intelligence. That's a challenge in the hierarchical public sector, but without that, stronger, more equitable and resilient, healthier communities will remain an unrealizable goal. Having worked with a number of STPs in the last couple of weeks, I think there's grounds for a huge amount of optimism. There is a genuine ambition for us to signal a sea change in the way that health and care services are designed and delivered here in England, with the patient and the population at the centre. I hope you found this webcast useful. Please do make contact with either Better Value Healthcare or Optimity advisors if you would like to hear more. Thank you.